Look, I think it's a pretty overwhelming condition for a young person to find out about. And I think the really positive thing is that there's lots of treatments now. This used to be a condition that, younger patients would go blind, and it just is not happening anywhere near to the degree. So I mentioned corneal transplants previously, but the rate of corneal transplants of keratoconus has like the curve is like this. So we don't do transplants for keratoconus anywhere near at the rates that we used to. So that's really positive, and that's since the induction of cross-linking. So cross-linking is a game changer. You're basically able to freeze the eye so it doesn't progress or get worse. And I think cross-linking, coupled with all the really clever scleral contacts that we have on the market now, and CAIRS, which is really exciting, I think it's a really different landscape. So I think if you're diagnosed with keratoconus and you're a young person, obviously it's something to take seriously, but there's definitely treatments out there. And I guess the only other thing I would say is just don't rub your eyes.
Over the past few years, there's been a growing awareness of keratoconus, a condition many people still haven't heard of, and of corneal cross-linking as a technique to help stabilize the disease. In today's discussion, we'll walk through how keratoconus affects vision, how it's diagnosed, when corneal cross-linking is a suitable solution, and what patients right here in Sydney should consider if they suspect they have corneal issues. I'm thrilled once again to talk with Dr. Erica Darian-Smith from Eagle Eye Surgeons. Erica is at the forefront of corneal and refractive surgery in Sydney, having trained both locally and abroad. At her clinics in Mossman and Penrith, she treats everything from cataracts to complex corneal conditions. But first, who am I? My name's Paul Salloway. I'm the owner of Optics Digital Marketing. We're an agency that helps eye care professionals to grow their practice. Hello, Erica. Good to talk with you again.
Hi, Paul. How are you going?
Very well, thanks. So today we're talking about keratoconus, and to be honest, it's not something that I really remember hearing much about until fairly recently. And talking with some of my optometrist friends, they have mentioned to me that there's some evidence coming out that it's actually maybe more prevalent in our society than we previously thought. So, what are your perspectives on it?
So I think that it's meant to have about a 1 to 2% rate of keratoconus in the community. I do think we are seeing probably a bit more, and I think it's multifactorial. So, I mean, keratoconus, what it is essentially is it's a condition where the cornea, or the front part of your eye, it's usually shaped like a soccer ball, so it has a spherical shape, and it basically becomes distorted and it becomes conical or cone shaped. So you get that cone shape, and at the tip of the cone, the surface becomes steeper and it becomes thinner. So they're like the characteristic, signs of it. And then you get the reduction in your vision. You get lots of astigmatism traditionally, and worsening short-sightedness. So, and then that comes with your blur and problems with your distance vision. Now, there's many reasons you can get keratoconus. There's obviously a huge genetic component. And then there's other external factors like severe allergy or atopy. So if you're a really bad eye rubber, you can trigger keratoconus. You probably already have some kind of underlying genetic predisposition, but it makes things worse, and it changes the shape of your cornea. Certain medications and certain syndromes that also can be linked to keratoconus. So there's different causes for it, but essentially it's a progressive condition. Usually happens in young patients. We see it most commonly in young males and females. There's certain ethnic or racial groups that are more predisposed to it. So we do see higher rates in some of the Maori and Islander groups, and also in some of the Jewish populations. So there's definitely, and also some of the some parts of Asia also have higher rates. So there's definitely a genetic component, there's definitely a racial component, and then there's the external factors like your eye rubbing, and all of these together cause this condition that's generally progressive. It usually stabilizes by the age of 40 in most patients, but again, variable. Medicine doesn't always follow the textbooks, but that's essentially what it is. And I mean, I guess we are seeing maybe a bit more in the community, but there's Also an added awareness now as well. So you have to kind of balance the two. I think there's just been a lot of undiagnosed keratoconus that we
Yeah.
previously didn't know it was there. And now because we've got better technology, so we've got all our special scans that we can look at the cornea, I think we're just diagnosing more cases. I don't know if it necessarily means that there's more. I just think we're
Mm.
noticing more.
Yeah. And as you mentioned, it's an interesting kind of condition because we're unlike, for example, myopia, which affects like young kids while their eyes are developing, and things like cataracts and AMD, which affects people as they get older. Keratoconus, it's something it seems to hit young adults, like you said. So
Yeah.
from the
Generally,
age of what, 20 onwards?
yeah, generally. I mean, I've seen it in a 12-year-old, I've seen it in
Yeah.
teenagers, 16-year-olds, but it's generally early 20s to 30s, and then it progressively gets worse if it's untreated or undiagnosed, if patients continue rubbing their eyes, and that because they
Mm,
just don't know that that's,
mm,
something that will exacerbate it. And then it usually stabilizes at around the age of 40. But, as I said, I've seen 60-year-olds progress. So it just depends on I think it depends on your genetics. I think it depends on whether you're able to stop eye rubbing, from whether it's from allergy or from severe dryness. There's
mm,
lots of reasons that people rub their eyes. I think also there's links with obesity, and CPAP machines can help with that. So positioning of your head when you're sleeping on a pillow, like if you're sleeping on a certain way where you're rubbing your eye, there's
mm.
been links with that as well. So it does impact on sleep hygiene. It does impact on also treating underlying exacerbating factors like dry eye and allergy.
Right. Okay. Well, so you mentioned diagnosis. So when somebody comes into your clinic, eagle eye surgeons with unexplained vision changes,
Mm-hmm.
how do you diagnose keratoconus? What are
Yeah.
the tools and techniques and steps that you follow?
Yeah. So I think we're lucky. A lot of our patients at Eagle Eyes are referred in by optometrists with keratoconus. So initially, what happens is patients say, "Oh, my vision is getting blurry." They go and see their optometrist to update their glasses, and then the optometrists are very switched on in the community, especially in Sydney, where I work, and they're able to see that there's increasing astigmatism or worsening myopia. Some of the optometrists have corneal topography machines, so they're machines that look at the surface of the eye and can see the change in the shape. So we usually get referrals as like keratoconus suspect. So patients come in as a suspect. I see a huge range. I see people that have basically subclinical, so they don't have symptoms of keratoconus. So that's in my laser workups. I see people like that all the time. To people that have severe keratoconus that are requiring corneal transplants. So there's
Mm,
important to note there's a massive range for keratoconus. And then when they come to our clinic, they undergo a series of diagnostic tests to stratify how severe or the keratoconus is. So we have a corneal tomographer, which looks at the shape of the front and the back of the cornea. So in keratoconus, you'll see that the back becomes more elevated and the front becomes steeper. And as I said, you get more astigmatism. So you can see the changes on these scans. And we have a pentacam and an MS-39, so that helps us look at the risk, so stratify the risk, and then we go from there.
mm. And so you mentioned astigmatism. So there is some difference, isn't there, between keratoconus and astigmatism? Can you just sort
Oh
of
yeah, absolutely. So
explain
some
that for
people,
us?
yeah, so some people will naturally have an eye shaped a bit more like a rugby ball rather than a soccer ball, and that's astigmatism. But that's not necessarily a pathological thing. That's just that you'll need glasses or contacts to correct that shape. Keratoconus is when not only is the eye, it changes into more a conical shape or a cone shape. So that's very different to being like an AFL ball. And that's a pathological condition. So astigmatism is not a pathology. It's just a type of issue with your refractive error. Doesn't mean that you're going to go blind from it. It just means that you'll need to have some kind of correction, whether it's in the form of glasses or contacts or laser eye surgery. Whereas keratoconus, because it's progressive, you're actually getting weakening of the collagen fibers at that tip of the cone. So you're getting more irregular astigmatism. So you're getting very atypical shape of that cornea, and that's actually hard to correct with traditional glasses or contacts. Laser eye surgery is contraindicated, so it's completely not allowed in keratoconic patients. Refractive laser surgery. I mean, you can do corrective PRK laser eye surgery combined with cross-linking, which we can touch on later. but I'm talking about your classic LASIK or SMILE. So that's the difference between the two, Paul.
And so is keratoconus something that would get picked up in a standard optometrist's exam, or is it something that you'd have to actually use, specialized imaging equipment to identify?
Most of the time, you can, as again, what I was saying, it could be a suspect. So optometrists can have a really strong feeling that someone has keratoconus, but most optometrists, some maybe do, but the majority do not have pentacam and an MS39. That's very much a subspecialized corneal specialist or ophthalmic clinic diagnostic testing. So, and to make the ultimate diagnosis and to manage the condition, you really do need to see a corneal specialist or an ophthalmologist.
Okay. All right. So, so you've diagnosed someone with keratoconus. Maybe it's at an advanced stage. So is this where you would discuss corneal cross-linking surgery and how does it help people with keratoconus?
Sure. So there's two components when you think about keratoconus. You're thinking the first component is visual rehabilitation. So you want to think about how can we improve the vision, and the second component is to stop the progression. So you actually you separate it into two scenarios, right? So cross-linking falls under the stopping progression. So with keratoconus, to stop progression, simple things that we can do is treat dry eye, get patients to stop eye rubbing. If a patient has sleep apnea or a problem, we can organise sleep studies and a CPAP machine through their physician. So these are things that we can do kind of with the GP and sleep and respiratory colleagues. Then in our clinic, we can offer cross-linking. So this is corneal cross-linking, corneal collagen cross-linking. So this is where I was talking about at the tip of the cone, those collagen fibers that are in the stroma of the cornea become weakened because of the shape of the cornea. This is a procedure whereby we basically strengthen those and freeze the cornea in time. So it doesn't reverse damage that's already done. We're just preventing future damage. So this can be divided into epithelium-on or epithelium-off cross-linking. We provide both options at our clinic. This is essentially where you're using a special chemical, so a type of vitamin B called riboflavin, and we drop that on the cornea for a period of time, and then we set that special chemical with a specific UV light. So, and then that basically strengthens those collagen fibers over a period of weeks to months, and then we monitor in the clinic with our scans and with our clinical exam to see if it's been effective. We offer both types. We offer skin on and skin off, and there's differences between the two. Essentially, the skin off has been around for a long time. So a lot of the traditional studies are based on skin off. So that's kind of like the gold standard. But lots of patients do opt for skin or epithelium on because it doesn't have some of the risks that removing the skin has. So when you remove the skin, you've got a slightly increased risk of infection. You've got a slightly increased risk of scarring or hazing of the cornea. And you've also got a bit more pain because the skin's being removed. So some of those things are reduced with the epithelium-on technique, but the obviously disadvantage of that is that it hasn't been around for as long. So we don't have really long-term data. So we don't know, is it as effective as epithelium-on for stopping progression? And there's been quite a few studies. There's been a large meta-analysis that Professor Watson in Sydney's done. So it looks like it probably is as effective, but we still don't have that 10, 20-year data. So I always tell my patients that they're given an option. Sometimes I'll recommend one over another for specific reasons, but we are lucky at Eagle Eyes. We have a great machine, so we can offer both options to our patients.
Okay. Well, I called it cross-linking surgery, but from the way you described it, it sounds like in some cases, like the epithelium-on option, it's quite non-invasive. So I'm not even sure that's a correct
It's definitely
characterization.
surgery. So we still do it we still do it in a sterile environment. We treat it as a surgery, but it's definitely less invasive for sure because we're not actually breaching the skin on the surface of the eye. But I guess you've got to just, as per everything, you've got to weigh the risks and benefits. And I give my patients the kind of papers and just the full array of information, and then we make our decision on each individual patient what we think would be best for them.
And sorry, is that something that you do at your clinics at Mossman and
Yeah.
Penrith, or is it
No,
actually in the hospital?
we just do it at Mossman, and then also you can do it at some of the private hospitals. So, like for example, at Chatswood Private Hospital, but we do it in house at our clinic in Mossman.
And how long does the procedure take? And is it something that's usually a day surgery? People can go home the
So
same
yeah, you
day?
go home the same day. There's different protocols, so I'm not going to get into it too much because again, that comes down to the severity of the keratoconus and the
Mm.
type of treatment. But basically, originally when keratoconus was first introduced, there was a protocol called the Dresden protocol, which was the gold standard or the classic, and that used to take about an hour. But now we have accelerated versions of this protocol, so they've been tweaked with a lot of data behind them. So usually now cross-linking takes anywhere from around 20 minutes or so, 20 to 30 minutes. So it's about half the time because we use a different concentration of the chemical riboflavin, and we also use a different concentration of the UV light.
Mm.
So we basically have accelerated programs that make the process a lot more tolerable for the patients. So usually around 20 to 30 minutes.
Okay. And you said that in some situations you can also do like PRK surgery along with that
Yeah, so
cross-linking. Is that right?
that's kind of a different, so that now goes into the visual rehabilitation, so improving vision. So we're moving
Mm.
on from the progression. So in terms of improving your vision, there's a few different options.
Yeah.
So the kind of initial option is obviously glasses or contacts.
Mm.
So if the keratoconus isn't too advanced, then the optometrist can prescribe glasses or contacts, especially if it's not too irregular. But then if it starts becoming a bit worse or glasses or contacts aren't tolerated, then you can start looking at pretty non-invasive things like scleral contact lenses. And some of the optometrists in Sydney are now doing wavefront guided scleral contact lenses, which is pretty state of the art. So that's basically using some of those scans that we have in our clinic to customize or shape the scleral contacts to make them individualized for our keratoconus patients. And these give phenomenal vision, and they're quite comfortable because they're quite wide. So patients usually tolerate those really well. All that's required is to remove them at the beginning of the day and at the end of the day, and put them back in at the beginning of the day. So there's a special suction device that can be done for that. So that's really what most of my patients are opting for now, because the technology with scleral contacts is just unbelievable, and we have really talented optometrists in the community that are able to make them.
Mm.
And then some ophthalmologists or corneal specialists will offer PRK. So we've spoken about PRK before, but that's a type of laser eye surgery, and they'll combine that with corneal cross-linking. So that's another way that you can improve the vision. And then that's called topography guided PRK with cross-linking. And then there's the patients that aren't suitable for laser, can't tolerate scleral contacts, glasses and ordinary contacts don't work. And then you're looking at more invasive procedures like corneal transplants, and more recently, CAIRS, which is a type of procedure where corneal transplant tissue is used. So real corneal tissue is used, and it's made in a little kind of custom-made arc segment, and this is placed inside the cornea, so under the surface, to try and offset some of the irregularity of the cornea. So this is obviously way less invasive than corneal transplants. And I do think this is a very exciting advancement for keratoconus. It's definitely a way forward for treatment. But you can see you've got many options. You've got glasses and contacts, you've got scleral or hard contacts, then you've got potentially in a small cohort of patients, the topography guided PRK combined with cross-linking. You've got CAIRS for some people, and then you've got corneal transplants. And then corneal transplants falls into full thickness and partial thickness. So you can see it's kind of mind-blowing how many options there are.
Yeah. All right. Okay. Well, so somebody's come into Eagle Eye Surgeons. They've had corneal cross-linking. What does the recovery process look like for them? So can they get back to work, within a couple of days? Is driving possible? Should they have, is there anything they should avoid? For how long?
Yeah. So again, it depends on whether we're doing skin on or skin off cross-linking. It's very different recovery. So we'll start with the traditional skin off. So that's obviously a bit slower. The skin is removed, so it takes about a week for the skin to regrow, and a contact lens is placed on the eye during that procedure. And then usually the vision improves around the 2 week, 1 to 2 week mark. And then usually there's fluctuations for the first couple of months. Patients definitely can't drive for the first 1 to 2 weeks. And there's quite significant discomfort, I would say, for the first 24 to 48 hours. And that reduces very quickly with the application of our contact lens, but also just because it passes pretty soon after. So that's your traditional epithelium off. Epithelium on, which a lot of patients opt for, is much, much different because we're not removing the skin. The vision will be a little bit blurry, but nothing like epithelium off. Again, you'll still get visual fluctuations for the first 3 months, but assuming that patients meet the driving guidelines in the first place, you've got to remember that lots of our keratoconus patients actually aren't suitable for driving. Depends how early in the piece that their keratoconus has been picked up. But assuming that with corrected vision, they are able to drive, then epithelium on, you can drive within 24 hours, assuming that the corrected vision passes the, legal driving requirements. There's only a little bit of discomfort on the first night, but no severe pain. And patients can get back to work within a few days. It's very different. So yeah, there's different process, different procedure really, but same outcome.
And so patients should, of course, really avoid eye rubbing or swimming or any other daily activities.
Yeah, so I mean, usual post-operative. So if you've had epithelium off, you can't swim for a few weeks, and no one should be rubbing their eyes in general. But definitely not post-surgery. And anyone who's got keratoconus shouldn't be rubbing their eyes. They need to be really mindful of how they're sleeping on their pillow. And we get them to use drops for a period of 6 weeks and to lubricate a lot as well.
Would they wear a patch at night, like with cataract
So we
surgery?
give all our patients plastic shields when they're sleeping for the first week at night. Even the epithelium on, I recommend patients use them for a few days because they've still had 2 different types of chemicals, put into their eyes. So with the epithelium on, we use 2 types of chemicals. The first chemical aims to penetrate through the skin, and then the second chemical does the treatment. So you're still going to be a bit uncomfortable and you might accidentally rub your eyes when you're sleeping. So we still get patients to use a plastic shield. I think that's just sensible. And obviously sunglasses when you go outside for the first week or so. But again, everyone should be wearing polarized sunglasses all the time when they go outside.
That should be a default anyway.
Yeah.
All right, Erica, well, this has been incredibly insightful as per usual. Any final words of advice for people who've been diagnosed with keratoconus or who are considering cross-linking surgery?
Look, I think it's a pretty overwhelming condition for a young person to find out about. And I think the really positive thing is that there's lots of treatments now. This used to be a condition that, younger patients would go blind, and it just is not happening anywhere near to the degree. So I mentioned corneal transplants previously, but the rate of corneal transplants of keratoconus has like the curve is like this. So we don't do transplants for keratoconus anywhere near at the rates that we used to. So that's really positive, and that's since the induction of cross-linking. So cross-linking is a game changer. You're basically able to freeze the eye so it doesn't progress or get worse. And I think cross-linking coupled with all the really clever scleral contacts that we have on the market now and CAIRS, which is really exciting, I think it's a really different landscape. So I think if you're diagnosed with keratoconus and you're a young person, obviously it's something to take seriously, but there's definitely treatments out there. And I guess the only other thing I would say is just don't rub your eyes.
Yeah.
It's just so crucial in the keratoconus management. But it's actually a positive. We have treatment, so it's more a positive discussion I have with patients now. It's obviously hard for them to hear, but then when they know that there's all these options, and cross-linking can be done in the clinic, and it's not as scary as it used to be. Patients are really appreciative, and I think it's actually really exciting and really fulfilling area to be in.
Okay, well, so where can people reach you if they'd like to book an appointment or learn more about their corneal health?
Yeah, so you can go on our website, www.eagleeyesurgeons.com.au. There's actually a whole section on keratoconus and cross-linking on there. And obviously, I'm always happy to see patients in the room. So I see patients at 2 spots, Penrith, at the Nepean Health Hub, just next door to the public hospital, and at our site in Military Road. So you can give us a call on 7228 3900 to make an appointment, or you can do that online through our website. And I'm always happy to chat to patients or to see keratoconic patients because we have good options for them now.
Okay. Well, if you've found this information helpful, then please hit the like button so others can discover it too. It really helps us out with the YouTube algorithm. Also, subscribe to the Eagle Eye Surgeon's YouTube channel for more content on eye health, and follow along on the Facebook and Instagram accounts for updates on the latest treatments and events. All right, well, thanks so much, Erica. Thanks everyone for watching.
Thanks, Paul. See ya.
Okay, take care. See you next time.